So welcome everybody, and thanks for attending our CARE TA cohort session today. My name's Sue Ann O'Brien. I'm the VP of Crisis System Integration for RI International. And hopefully you were here last week for Dr. John Draper's great overview of the history of crisis lines in this country, starting with 911 and how we got to where we're at today with the implementation of 988. Today, we're going to take that one step further and take a little bit of a deeper dive. And we're really excited to have two national experts with us today. John Draper is currently with Behavioral Health Link. He is going to kick us off. And also Sherry from DD Hirsch.
Really excited to be working alongside yet again with my old friend and colleague, Sherry Sinwelski. Sherry and I spent many years doing whatever we could to build a national network that would soon become a 988, and happy to talk with you all about how 988 is looking now, how hopefully it will look over time, because we are still building it. It's very much in the early stages of evolution, I would say infancy. So over the years, we'll see some transformation like we are only imagining now. I'll tell you a little bit about what we're imagining in just a little bit. Let's talk about what's happening right now. It's a different situation with 988 than it is with 911 in a number of ways. One of the ways is that the way in which calls are routed and eventually connected to a counselor are quite different. With 911, you contact 911, you dial those 3 digits, and it goes straight to the local public service answering point. Here with a Lifeline, it goes to the Vibrance telephony platform, which is operated through Intrado. It's a centralized routing system that looks at your area code and matches it to the state and then routes it to the supposedly nearest center to that area code. Now, obviously, you know, with cell phones, a person could be anywhere with an old area code that doesn't really match their location. That geolocation challenge is still being taken up at the federal level. And until then, Vibrant is routing calls by area code. Now, when the area code, when you dial 988, you hear an automated greeting, an interactive voice response that gives you a few options. It asks you to press 2 if you'd like to access Spanish language services. If you're a veteran or a member of military service, it suggests that you press 1. If you're LGBTQ youth or concerned about such youth, you can press 3, which again is a new service that 988 has been offering. Actually, in Washington, you can press 4 for the Native and Strong line, a new, really thrilling service for individuals who are trying to access services for American Indian, Alaskan Native needs, and answered by individuals who come from tribal communities. And then it routes to the local center in the event that you don't need any of those services. It says, just hold on, we're going to take you to the nearest center, and then you wait while music plays. And then when a counselor is ready to pick up the line, they will intercept that call in the queue. They'll receive it by pressing 1, basically confirming that they're ready to receive the call. That's how Vibrant determines that a call has been answered, through a queue that's entirely independent of theirs. So that is quite a journey. In fact, 55 seconds wait for everybody going through the service, unless they already know to press 1 or 3 the moment that they hear the greeting. But otherwise, they're waiting for about a minute. And we'll go to the next slide to give you a sense as to who is answering the call. Now, for pressing 1, Veterans Crisis Line, that's picked up by one of 3 centers typically in the Veterans Crisis Line subnetwork. That includes a center in Canandaigua, center in Topeka, Kansas, and a center in Atlanta. Now, none of those can pick up. La Frontera Impact in Arizona, which is a center in the Lifeline network, will answer those calls to make sure that all Veterans Crisis Line calls are responded to. Now, if you press 2, the Spanish language subnetwork consists of 4 Lifeline centers, including DD Hirsch, and pressing 3 The Trevor Project, plus a backup center, Community Crisis Center, Lifeline Center in Maryland, would be picking up those contacts. Now, right now, there's an RFP that is being provided through Vibrant or offered through Vibrant for other centers that may want to join the LGBTQ plus youth subnetwork. So that is likely to expand over the coming year. Now, again, if you don't press any of those and you connect to a local center, there's about 200 local centers across all 50 states. And as I mentioned before, connected via the nearest area code. But if they are unable to answer, calls will roll over to the National Backup Center. So there's 17 Lifeline centers that are designated and paid for to answer all of those national calls, no matter where they're coming from. There's also chat, text, and TTY services. About 25 Lifeline centers are answering chat and text nationally. There's only Trevor Project is answering the LGBTQ chat and text currently. That again will change in the coming months. And Deaf Lead for the Deaf and Hard of Hearing, which is a crisis service organization operating out of Columbia, Missouri, who specializes in working with deaf and hard of hearing populations, is answering the 24/7 TTY line. We expect probably in the next few months that they will also be answering, as well as other deaf and hard of hearing services, a video conference line, which will be the first that 988 will be offering. How's it going so far? Since July of 2022, I'm just going to give you the first 6 months. You can go on the 988 website for SAMHSA to see how things have been going this year. But for the first 6 months, we saw about a 30% increase in calls between July and through December of last year. But what I think is particularly remarkable is the change in the response time and rate. First of all, with chats, prior to 988, Lifeline was answering only 24% of chats. Take a look at that orange line there, 96%. Now you look at text, 52% pre-988 launch, 99% post-launch. Most recently, it's still at 99%. Calls, about 81% were being answered prior to 988's launch, 87% now, and another overall huge increase between pre and post-launch. 64% of all contacts answered, now 91%. So we're seeing what funding can do. The crisis centers, all they needed essentially was more resources, and they're getting that. So that's improved the average speed of answer from 3 minutes pre-launch to 44 seconds now, and that's across all modes. And the average talk time is about nearly 22 minutes, and that's again across all modes of service. To give you a sense of the variation across the states in terms of answer rates, not all states created equal in terms of funding, and that really is the issue, is that as you see, more resources means better answer rates. And in the very dark blue states here, over 90%, between 90 to 100%, there are 12 states that are answering at that rate, including the District of Columbia. In the dark blue, but not heavy, intensely dark blue, about 22 states are answering the 80 to 89% range, and that includes California. Lighter blue, about 9 states, 79%, and then under 70% is in the orange. How do we expect that things are going to change with 988 regarding the Lifeline, which has been around for a while? Well, naturally, if you have a 3-digit number that is designed to increase access and visibility for a number, you're going to hope that its scale is going to increase, that there's going to be a lot more people contacting the service. So I mentioned it's about 30% now, but we do expect in the next few months, there's going to be a massive campaign for 988 that's being funded by the federal government, be overseen by SAMHSA and a community of partners that will be getting the 988 number out in a way that hopefully penetrates awareness everywhere. And that could mean, we estimate, anywhere between a 2 to 4 times increase over the coming year. So again, what we're seeing now is just a morsel of the experience for 988 in the coming years. So the need for more resources is going to be increasingly acute over time. The scope of the service is changing a little bit, very focused on suicide and with the National Suicide Prevention Lifeline. We did get a number of people phoning in emotional distress, but now it is really being advertised as a suicide and mental health crisis line, behavioral health, in fact, substance use as well. But in general, it's a suicide and crisis lifeline. And the emphasis is on the crisis care continuum. It's not just about contacting 988. It's what happens behind that front door of 988 that we're also wanting to emphasize. The availability of mobile crisis teams, which I'll talk about momentarily, as well as crisis receiving facilities that are alternatives to the emergency department. We want to make sure that this service has more equitable access. And that's going to be really essential for people with functional, linguistic, and access needs. So everybody, 988 is about increasing access. And so we want to make sure that everybody is going to be able to access this service and do so through omni-channel services, whether it's call, chat, text, as well as outbound calls and contacts. It could be chat or by email, text, and phone from the centers for high-risk individuals. Also, you're seeing the evidence of more specialized services, and expect more over the coming months and years. LGBTQ+ youth is a new service. Again, just starting with 988. We've never seen that as a part of 988 before. Never seen anything like what we're seeing in Washington now with the American Indian Alaska Native line, and hopefully there'll be many more of those. We know there's also a need to focus on outreach to communities of color, other marginalized communities and rural individuals, other high-risk populations. There is specifically in the most recent legislation a stated need to reach more youth in crisis. So expect more youth-related services. And there's a lot more stakeholder investment in 988. It's really intended to be a shared responsibility for both the federal government and the state government. The Fed ain't going to pay for it all, and the states ain't going to pay for it all. You're going to see, because it's an issue at both the state and federal level, and obviously, most importantly, at the community level, and that's the reason for those local community crisis centers. And what's really local is the crisis care continuum. Even though the crisis lines don't need to be in every community, mobile crisis teams need to be, and so need to be the crisis receiving facilities, as well as any wraparound services. And you'll see at each level of the crisis care continuum that you would hope to screen out the need for any further interventions. 80% of the time with the crisis contact lines, we should be able to resolve those contacts through that service. That's not the way 911 operates. It's a dispatch service, but only 20% of the time should we be dispatching anything from mobile crisis teams to emergency services. But we also, when we do need to put somebody in a place where they can get help and go to a place like a crisis receiving facility, hopefully those will be alternatives to emergency departments. And you can see at each level, we hope to keep people in the community and away from jails, emergency departments, and inpatient units. Now, what I just described is what the ideal is for the Crisis Now model. Crisis Now came out in 2013 and influenced the national guidelines for crisis behavioral health services that was released by SAMHSA in 2020. And those guidelines outline some specific things that need to be there, and I just mentioned them. That's the contact centers should be in every state, in every community. There should be also coverage of mobile crisis teams and crisis receiving facilities. How many of the states have all of these combined? Well, the National Association of State Mental Health Program Directors has a research arm. That's the National Research Institute. And they provided a report following the survey that they did of all the state mental health authorities in March of 2022. And you'll see in the green the number of state mental health authorities that reported having all three Crisis Now components: contact centers, mobile crisis teams, and crisis receiving facilities. That looks pretty good. That doesn't mean necessarily they're statewide, and I'll get to that in a moment, but they have them somewhere, somehow, in those states. Now, there's 3 states here that did not report. So this is it says 48 state mental health agencies. Probably also includes the District of Columbia too. Call centers and mobile crisis only, that's in the blue. So there's a few states that only reported having those two elements. And in that kind of yellowish orange, you'll see only call centers. That doesn't mean necessarily that Wyoming and Florida only have call centers. It means the state mental health authority only knows of the call centers. They may not be funding any mobile crisis teams that are working out there. But it does suggest that if there are mobile crisis teams, they're certainly not coordinated with the funded facilities. The mobile crisis services, how many of them are across states? Well, that same National Research Institute report, there was about 44 states actually that responded. There was a few that did not respond here. And there was two in yellow that did respond, but didn't report how many mobile crisis teams they have. Now, what you see in red here are the states that had 21 or more mobile crisis teams. However, what you see in the kind of orange dotted, that's Wyoming, they reported no mobile crisis services. Again, there may be some, but not to the awareness of state mental health authorities. In the dotted blues, you've got, I believe, South Dakota, Kansas, Arkansas, Maine. Those are about 1 to 5 mobile crisis teams. The NRI survey looked at some of these other data points that are really important, determine who is actually running these mobile crisis services, who's funded to operate them. About 96% of the areas reported having mobile crisis teams operating, and that's about, again, across 44 states here. And so not all the states are reporting, about nearly 1,300 teams. With quite a number of individuals served by mobile crisis teams last year, so about 412,000. But you'll see the type of providers. There's the other community behavioral health providers, and what we mean by other here is other than the certified community behavioral health centers, which obviously are other community behavioral health providers. And State Mental Health Authority operates some mobile crisis teams and funds them directly. What's also true is that about 86% of Lifeline Crisis Centers reported when Vibrant surveyed them a couple of years ago, about 86% of them said that there was mobile crisis teams somewhere in their area. But about 40% of those crisis centers said that they were operating those mobile crisis teams. So that suggests that they're pretty well coordinated with some of those 988 centers in the network. How many mobile crisis teams are covering the entire, or how many states have entire statewide mobile crisis coverage? Well, of those reporting, only 24. 20 said that there were only some regions of the state that had mobile crisis in it. And some said, actually most said that some are not 24/7. So only 20 reported full 24/7 service, and one said none of our services are 24/7. Some of the barriers to expanding mobile crisis service, and state mental health authorities in that survey said, well, about 78% of the time, there are significant challenges to us really expanding these crucial resources. And the biggest reason, the 33 cite, is workforce. And a lot of these overlap. Workforce is certainly overlaps with rural and remote service, as does transportation. There's transportation problems in rural and remote areas. There's also transportation problems in urban areas where there's significant traffic delays. But the workforce issue in rural areas is quite significant, and especially if you want 24/7 service. So 24/7 service and rural combined, those things really do affect the scarcity in workforce. There's just harder to find people to work those shifts. The crisis receiving and stabilization facilities availability, part of that part of the crisis care continuum, 36 states reported that they funded these types of facilities, and 8 said that they're available statewide. But most say that there's just some regions of the state. So there's quite a lot to be done in terms of establishing more crisis receiving and stabilization facilities. And when they are established, most of them are 24/7, but not all of them. In terms of the spending that's being done for the various states, about 39 states reporting here. So this is an underestimate, but it will give you some sense as to who's getting what? The Lifeline centers, while you see the total funds for them are less than some of the other services, mobile crisis and crisis stabilization residential, there's just fewer Lifeline centers. So they're actually getting a larger piece of the pie. About $1.8 million per center is being provided across 40 states. And then you'll see that obviously with the crisis receiving stabilization, residential and mobile crisis, which are typically more expensive types of care, they're getting less. But again, the Lifeline centers are the front door and can resolve about 80% of those crises. So that's the reason that is being funded first. But we have a long way to go to support mobile crisis and crisis receiving and stabilization services. And the states are doing whatever they can to promote more legislation that can fund those services. Many of you know about the cell phone fee. Only 5 states have a 988 fee that's charged to your monthly cell phone. California being one of them, and Sherry certainly may speak about that. Other 8 states that have created a 988 advisory board, 12 that have had a trust fund established for the 988 services, and 5 have strengthened their crisis care insurance coverage. Another 5 studying 988 financing or gaps in their crisis system services capacity, and 29 have passed appropriations for any of these 3-4 crisis services. So we are seeing some movement, some significant movement in ways that we've never seen before for crisis services nationally. What's happening at the federal level? I'm going to just talk a little bit about that before I turn it over to Sherry. But what we began seeing a lot of funds flowing for crisis services beginning in fiscal year 2022. First of all, there's a new state Medicaid option for mobile crisis services. There's 5-year funding for the first 3 years. It has an 85% federal match, and California has taken advantage of that. California's DHS has provided $150 million from Behavioral Health Continuum Infrastructure Program for mobile crisis services, with $55 million of that from the federal matching via the American Rescue Plan Act. Now, the most recent omnibus budget is a huge gift for the 988 and is really showing a federal commitment to what 988 needs to become. And from the crisis care continuum standpoint, you'll see that over $500 million for 988, that's $390 million more than last year. They wanted to increase the capacity for Spanish speakers. I mentioned youth, follow-up services, the public awareness campaign, and also increased Medicare payments for the crisis services in the way I was talking about previously. But the state block grants are massive now. For the first time, they've crossed the 1 billion mark, and all of them have a required minimum 5% crisis services set aside. So we're really moving in the direction of funding crisis services in ways we've never seen before. And I'd like to turn it over to Sherry, who's going to tell you a little bit more, not only about the national, but more importantly, about what's happening in California. Sherry?
I'm Sherry Sinwelski. I am Vice President of Crisis Care at D.D. Hirsch Mental Health Services. So D.D. Hirsch is one of the over 200 centers that make up 988 across the country. So there are centers all across the nation that make up 988, and there's 12 in the state of California. We'll talk a little bit about them more as I go through my presentation. But D.D. Hirsch serves as the lead of these centers in the state of California. I wanted to note, though, that while 988 is very new and exciting, obviously, with the launch that we just had in July of last year, 988 builds on a rich foundation of crisis services as the National Suicide Prevention Lifeline. And I'm not going to go through each one of these dates one by one, but as you can see, beginning in 2001 up until we are to date, there's been lots of work that's happening in crisis services through our old number 1-800-273-TALK. And the centers in California, many of them have a history that significantly predates this history here. As a matter of fact, D.D. Hirsch being one of the oldest, if not the oldest crisis hotline in the country, the other being up in San Francisco, the crisis hotline history in the state of California really is significant, and people really look to the state of California for a very strong and expert, the expertise of suicide prevention and crisis services in the state of California is long. And I realize I have a typo here on this slide, sorry about that, is really long, and we're really proud of that history. And that history is important because the work that's being done on the crisis hotlines is not new, and the work that's being done to train counselors and to establish best practices is something that has been really utilized through best practices and research in our work with SAMHSA and Vibrant, the administrator of the line. And so we're really proud of that history. As you all probably know, 988 is a network of independently operated and locally funded, now state funded and federally funded at times, crisis centers across the country. So it's a national portal for connecting to local services. We went live in July 2022, and the number is available to anybody across the country, free of charge. When people call it, they are routed by their area code to their local centers, as John already mentioned. People can still reach us through our old number, though, and that will continue to be available no matter what. So if people don't remember the 988 number, or they still have old materials with our old information, they can still reach out, and we will always be answering that as well. They'll always still be able to access us. As I noted, there are 12 centers across California that are providing local services for California residents. So depending on a caller's area code, they will reach their local center here in California. And we, D.D. Hirsch, as the lead for the state of California, we contract with the state, and then we subcontract with these centers. So we provide technical assistance to those centers, and we also kind of act as the administrator for the financial aspects of their contracts as well. And you can see here in this chart the 12 centers that we partner with. And many of these centers I know you will get a chance to hear from in the next few weeks as the additional webinars are presented in the series. So we've got 12 centers across the state that represent different regions based on area code, and D.D. Hirsch also serves as the backup for the entire state of California. Now, of course, last year represents half a year with 988, half a year without 988. But last year alone, in that kind of a mixed year, we answered 264,000 calls in California. And I anticipate that it will be much greater in calendar year 2023. One of the things that's also changing for us with the implementation of 988 is that we are also looking to bring all of our texts and chats for the state of California in state as well. So John talked about routing of calls in the state of California and how that worked. Right now, routing for text and chats is happening more on a national level because the infrastructure for that service was really implemented much later in the history of the Lifeline, and not all of the centers were providing text and chat, and funding really wasn't available for that. Now with the implementation of 988, funding has become available, and California, we're working with all of the centers to begin to implement local text and chat coverage as well. We currently have 4 of these centers are providing text and chat coverage, and we hope that by the end of 2024 that all of them will be doing that. So if you're wondering what counties these centers are covering, in this slide here, you can see more specifically, if the map was a little hard to determine the actual geographic coverage areas, you can take a look here at this slide and see the coverage areas for each one of the centers across the state of California. John kind of covered this, but nationally last year, I said we had about 264 calls in California. Nationally, in all contacts, we saw about 4 million across the United States in terms of all of the different contacts that were coming in. And if you wanted to have a little bit more specificity in terms of what we saw in California since the launch of 988, here's a few statistics to take a look at. So during the first kind of 6 months, this was the first 6 months since the launch of 988 here in California, we saw about a 22% increase in contacts across all modalities. So that's chats, texts, and calls. We saw, I'm not sure why these keep advancing. I'm sorry about that. We saw that about 40% of our contacts were from young people, ages 24 and under. Callers reaching out about somebody they were concerned about increased by more than 150%. So people calling for somebody else, that we saw an increase there. Our callers, texters, and chatters were predominantly female. 54% female, 43% male, 3% transgender, non-binary, or other gender. 58% of our calls, texts, and chatters came from, our calls, checks, and chats came from Black, Indigenous, and people of color, as well as those who are identifying as multiple race or other races. So that's just some general information about the people who were utilizing 988 in the first 6 months of the launch. You know, I talked about the fact that we are built upon the strong history of the Lifeline. And one of the things that's really important about that is that, you know, our studies that SAMHSA has done of the Lifeline show that the Lifeline is proven to work. That people who call into the service have noted, you know, to be, after calling, that they're less suicidal, less depressed, less overwhelmed, and more hopeful. It's been also noted that seriously suicidal individuals do call the Lifeline. John mentioned that, you know, the scope of the Lifeline is broadening, but it's still important to note that people can call the Lifeline, you know, in the deepest, darkest moments when they're thinking about suicide, and everybody is trained and ready to listen to that. And that, you know, our history shows that there have been significant decreases. So the Lifeline is built on some strong evaluations that have been done by experts in the field, including Maddie Gould, John Califat, and others. And it's been proven that both that seriously suicidal individuals use the Lifeline, even though it can be used much more broadly, obviously. The evaluations that have been done of the Lifeline that show that people that call into the Lifeline, you know, because of the significant training and skills of the counselors on the line, they report significant decreases in intent to die and hopelessness and psychological pain over the course of their call. So people call in, at the end of the call, they report being less suicidal. But another indication that was found in some of our evaluations is that there was inconsistency amongst counselors across the Lifeline in terms of their utilization of emergency intervention when they determined that somebody might be at risk for suicide. And so that led to the development of standardized guidelines for what counselors should do when a person was at imminent risk. They were called, at one point, they were called our guidelines for callers at imminent risk. They're now called our suicide safety policy. So this is a policy that is utilized across the network that really standardizes how counselors and centers must handle interactions with people who are at risk for suicide. And this is really important, and I'm going to talk a little bit more about these in the next slide. So if you can go to the next slide, please. So determining when a person may be at imminent risk, it's one of the most challenging things that counselors learn to do on the lines. We do this by utilizing our 4 core principles of risk assessment, and you can see those on the next slide. These 4 core principles of suicide assessment, they're part of our suicide safety policy, include suicide desire, suicide capability, suicide intent, and suicide buffers. So these are 4 areas that our counselors are trained on across the network. Any counselor that's answering a 988 call in all of our 200 centers are required to be trained in these areas. And so they're really trained to be listening to a caller's desire for suicide. They're listening to determine what's the caller's intent. Have they made a plan? How likely are they to act on that plan? Do they have the capability to do that? Do they have access to means? Have they tried to kill themselves in the past? How likely are they to act on that intent and that desire? And then what are protective factors in their life that might keep them from acting on that? So these are things that help them to determine how imminent is this situation. The good news is that in most cases, it's either not imminent or the counselor is able to de-escalate that situation so that it is not imminent. In fact, in 96% of those calls or texts or chats that come in, the call and the text or the chat is de-escalated and no additional intervention is needed. They're not, there's nothing else needs to happen after that call. Now, we might give additional resources for counseling or financial assistance or some other need that might need to be met, but no immediate intervention is needed. But in some cases, it may be determined, you know what, I'm not sure if this person's going to be able to stay safe. So then what do we do? So that's when the next part of our suicide safety policy goes into effect. When a person is deemed to be at imminent risk, or if an attempt is in progress. And so that's where we must implement kind of the next bullets that you see underneath that section of the slide, which is that our counselors are trained to work to promote that the person that they're in contact with is participating in securing their own safety. They're trained to actively engage that individual in efforts to increase their own safety. So, you know, they're really trained to develop a rapport with them, to help to understand what is in their life that might help them to come up with a plan to stay safe. Who might they be willing to talk to about what's going on? Is there a person in their life that they can talk to? Is there a particular coping mechanism that they usually turn to that helps them to feel better? Is there something that they feel comfortable with that they are willing and able to do to take the next step to stay safe? So what we're hoping for is that they're working towards the least invasive intervention, and that they're only initiating emergency intervention as a last resort. If despite attempts to de-escalate the situation and collaborate on less invasive interventions, the individual at risk is unable or unwilling to take action to secure their own safety. And this is really important because this is at the heart of what we do on the Lifeline. You know, sometimes people who are wondering what happens when they call into 988, you know, well, what's going to happen if I say I'm thinking about suicide? It's really important that they know that, you know, sending someone out is very unlikely to happen on a call, and when it does happen, it's only when a person is in really immediate danger, and we're working with them every step of the way to try to do it in a way that feels safe for them. And like I said, only 96% of our calls de-escalate, and only about 4% require any type of intervention. And even less than that are interventions that include any type of law enforcement. Oftentimes it might be also mobile crisis. It might be them going on their own to the emergency department or other types of intervention. I'd like to go down to the next slide, please. So I want to talk a little bit about some of the numbers. These are numbers that are, the first chart are actually some national numbers that I got from James Wright from SAMHSA just about the numbers of calls that are coming in nationally that are looking at calls related to suicide risk. So when we look at calls where the caller was indicating that they were having thoughts of suicide, we saw about 23% of calls indicating that they were having thoughts of suicide. About 82% of chats where they were indicating that they were having thoughts of suicide. About 83% of texts that were indicating that they had thoughts of suicide. Now, you might be wondering, why is there such a difference between calls, chats, and texts? You know, there's a couple of reasons why that might be. One of the biggest reasons probably is that on chats and texts, we have what we call our pre-chat survey. What that means is that when people chat or text in, there's an automatic couple of questions that they're asked before they speak to a counselor or chat or text to a counselor. And one of them is directly they're asked, are you having thoughts of suicide? So it might be possible that people are more inclined to answer that question truthfully when it is presented to them in writing than perhaps that when it's presented to them via direct question on a telephone call. We're not sure. It might also be that we see that people who are chatting and texting in skew much younger. So the people who call in are typically a bit older in terms of their age than people who are chatting in or texting in. We might be seeing higher rates of calls and of chatters and texters who are having thoughts of suicide than those who are calling in. So there's more work to be done there to understand some of those nuances. But across the board, no matter what methodology or modality people are using, we're still seeing similar types of de-escalation happening across all of those modalities in terms of intervention. And I've already noted that in California, in the first 6 months since the launch of 988, like I said, approximately 96% of our contacts were resolved without the need for further intervention. I wanted to talk specifically about a few special things that are happening here in the state of California that you all might want to know about and even chances to get more involved. If we take a look at the next slide. Oh, actually, I think it's the slide after this, but we take a look at the next slide for a second. So what are some of the differences between 911 and 988? When you're thinking about 911 and 988, I think the thing that's really important to recognize is that 911 is something that in our society now, people are used to dialing 911 and having someone come out to their home. Almost always when somebody's dialing 911, they're going to have somebody dispatched to the scene. That is not the case with 988. When people are dialing 988, it's most likely that that individual is going to have a chance to speak to a caring, compassionate, trained counselor, and whatever their emotional crisis is, whatever their concern is, they are going to have that situation de-escalated, and they're going to have an intervention that happens in the context of that contact via chat, text, or call. So people can call 988 when they have an urgent suicide or mental health crisis, and they call 911 if somebody is in need of immediate dispatch, someone to come out to their house. But we're working very closely, if we go to the next slide, we're working very closely with 911. And we're working very closely in ensuring that when people do dial 988, that they have access to the additional services that John was talking about earlier. So here in the state of California, we're building those building blocks. You've probably heard lots of people talking about that three-legged stool. So we have had the passage of AB 988 here in California, as John mentioned, which has given us the ability to really focus on the first leg of that three-legged stool. We've done a great job in really starting to secure building a really firm capacity for having a strong crisis center foundation here in California. John was talking about that map of the dark blue and the slightly lighter dark blue. And, you know, he had to point out that California was in the slightly lighter dark blue, a little thorn in my side every time I see those statistics, because we're always hovering right about 89%. And actually the last couple of months, we've gotten to 90% in a couple of months. We've actually hit into that dark blue, but we haven't always stayed there. Then we kind of go back down to 89%, but we're hovering 89, 90% every month. And I'm confident that in the next year, we are definitely going to stay above 90% and even higher, because I know what the crisis centers are doing in terms of hiring additional staff to continue to answer the increase of calls and texts and chats that are coming in. And so I'm really confident that, you know, over the next couple of years, our first leg of this three-legged stool is going to be a strong one. And we will continue to then build upon that, so that when people call 988, we will also be able to connect them to mobile crisis response teams, hopefully in line with the SAMHSA goal of having 80% by 2025, and potentially by 2027, having crisis stabilization centers in place as well. And I know that the state is working on a plan to try to correspond with that as well. If you go to the next slide, slide number 38, some of the ways that we're trying to make that vision a reality in California is through the California Unified Platform for 988. So what this is a telephony platform that's being implemented by Cal OES, the California Office of Emergency Services. They are in the process of putting together one platform, a technological platform that will allow the 12 centers in California to take calls, texts, and chats all on the same technology platform. Right now, we all operate on separate systems, which makes it really challenging for a variety of reasons. It makes it challenging for us to report. It makes it challenging for us if we want or need for some reason to transfer a caller to a different center. It makes it challenging if we wanted to start to move into the mode of doing mobile crisis dispatch at some point. But we're really excited about the fact that with the help of Cal OES, that those technological challenges will be a thing of the past for us, hopefully, within the next year. Some of the centers will be coming onto that new platform, actually, you know, in the next couple of months by the end of June. And the second cohort of centers, not, you know, probably in six to 9 months after that. So we're really hopeful that that new platform will really help us to get to that vision of an integrated system, you know, sooner rather than later here in the state of California. One of the other things that Cal OES is doing with some mandates through AB 988 is they are hosting the 988 Technical Advisory Board. This board has 3 work groups: a best practices working group, a 988 911 interface working group, an accessibility and equal access working group. So these are all working groups pulling together stakeholders across the state with experience and interest in any of those topics to help us to continue to build out our 988 system. So if you all are interested in learning more or contributing more to the system as it's being developed, I encourage you to take a look at joining one of those working groups. I was mentioning working more closely with 911, and one of our goals is also to be able to seamlessly divert callers who call 911 into the 988 system. So if an individual is calling 911 because they're having a mental health crisis, but really do not need police dispatch, the goal is ultimately that any caller who dials 911 in California can be seamlessly and easily routed into 988. That's already happening in some pilots in different areas, including in LA with Didi Hirsch. And the hope is to implement that across the state as well. 988 Mobile Crisis Collaborations group that Dee Dee Hirsch has hosted with the 988 centers, and our 911 diversion program that I've already talked about. So
all right. Well, I thank all of you for your time today. And we have 6 more sessions scheduled in this 8-session cohort. Special thanks to Dr. John Draper and Sherry for joining us on this incredible presentation.